Hello everyone and welcome to this webinar organised by Mobile Health and Waikato District Health Board in support of the New Zealand Sepsis Trust on World Sepsis Day during Te Wiki o Te Reo Māori. Ka tangi te titi, ka tangi te kaka, ka tangi hoki a hau, ti hei Māori ora. E ngā mana, e ngā reo, nau mai, haere mai, ke kirikiri roa. Ko Paul Huggin toku ingoa. I'm an infectious disease specialist based here at Waikato Hospital, and I'm joined by my colleague Dr. Robert Martinoga, an intensive care specialist and also originally from the south of Scotland like me, as well as Odette Paul, who's a nurse coordinator for sepsis quality improvement at Waikato District Health Board and who's been busy raising sepsis awareness around campus for World Sepsis Awareness Week, culminating in World Sepsis Day today. I'm very pleased to introduce our special guest, Korrin Barrett, who suffered a prolonged intensive care admission due to sepsis when she was living in Australia. Corin has since moved back to New Zealand and is committed to improving the lives of others by sharing her story, which she will be doing with us in a few moments. Information about sepsis is available on the New Zealand Sepsis Trust website, www.sepsis.org.nz, and also on the Health Navigator website, www.healthnavigator.org.nz, search sepsis. You can follow us on Twitter at SepsisTrustNZ, and for those joining us live, we're taking questions throughout for Corin or any of us on the panel. If you want to find more about Corin and her work, visit www.corin.nz or follow her on Facebook or Twitter at Korrin Barrett, RRRTT. So before we go any further, I thought I might ask Robert Martinoga to give us the easy and the hard explanation for what sepsis actually is, which is what we're talking about today. Robert.
Oh, thank you for having me along, Paul. Very interesting to be part of this webinar. So in essence, sepsis has been called various things over the years, and really it's about the concept of blood poisoning or infection in the bloodstream that results in the body becoming very, very injured. And people may have heard of the term septicemia, which is a little bit old-fashioned now, and blood poisoning itself is quite well known too. If we delve a little bit more deeply, we realize it's a bit more complicated than that, and really the modern terminology in the medical linguistics of it would be the idea that the body's immune system mounts a response, and that response is not always well regulated, and the dysregulated response to infection is really the big problem that we see as sepsis, and then this concept of septic shock when the body's organs start to struggle and then they start to fail, and without urgent intensive care and early supportive treatment, people start to deteriorate and may even die.
So thanks for that. So Corin, you're the only one of us who've actually had sepsis. Tell us a bit about yourself before we go any further.
Sure. So I, as you mentioned, have moved back to New Zealand, and I live in the beautiful Hawke's Bay. Extremely lucky to be home, and I did live in Australia for 10.5 years, and this happened to me back in 2012. So it's almost my 7-year anniversary to the day, which is a little bit scary. But yeah, so I am now a motivational speaker and like to share my story and be a mentor and ambassador for people who have been through similar situations or currently going through some sort of traumatic event. And yeah.
Well, thank you again for those of us that have had the pleasure of working with you for your openness about what's happened. Just for the people joining us, Corin has given us permission to share some of her medical story. Corin was in hospital after a relatively prolonged illness that involved her bowel in 2012 and had a procedure and was on an inpatient hospital ward when she developed signs and symptoms of sepsis. And as we've been teaching and training people about sepsis, we realized that a lot of those key symptoms and signs are not very well understood. So Corin, you were going to share with us some of the key symptoms of sepsis, not just telling us what they are, but what they actually felt like. One of the key symptoms of bacteria or bugs in your bloodstream is this rigor, this uncontrollable shake. Can you tell us exactly what that felt like?
So at the time, that actually happened before I presented to the hospital. So I I just remember being on the couch, and it was a Friday evening, and I did have this uncontrollable shake. It felt like I was having huge fever. I was sweating profusely. I just couldn't control the fact that I was, like, my teeth were chattering, my whole body was shivering, and I just had that sense of impending doom, so to speak, that sense of I'm really, really unwell, and there's definitely something pretty serious going wrong here.
So one of the questions we often get asked around this issue of shakes and chills, it was easy for you presumably to recognise that something was badly wrong, and that shake wasn't just the kind of chill that you get when you've got a cold or a cold and a cough. Is it fair to say that it was very distinct and easy to recognise?
Yes, but I think also at the same time there's a few other things going on, so you're associating, like I had quite a bit of abdominal pain as well, so part of me was thinking, is it associated to the pain? Is it my body's reaction to that? And then obviously you stop going to the bathroom as well, which is another. So these are all things that I didn't know at the time though. Yeah. Like I didn't know that they were all signs of sepsis. I just associated. I didn't associate them all together, if that makes any sense.
So in 2012, when you had a rigor and a number of other symptoms which we were going to talk through, did sepsis come to mind? Did it even cross your mind that there was this illness that had you ever heard of?
No, I had heard of septicemia, but never associated it with what I was currently going through. I just knew that I had something wrong, and I was putting it back onto the procedure that I'd just had to identify my bowel condition. So, I didn't hear the word sepsis until well into my ICU journey. Okay.
Which highlights the importance of awareness. I guess if you thought, could this be sepsis, you might have asked the question at the time.
Absolutely.
So working through some of this symptomatology, these symptoms you experienced, you told me that you had stopped passing urine. That seems to be a bit unusual.
Yeah. But I also didn't think anything of it at the time because I think I was too focused on everything else that was happening. So it wasn't even something that when I presented to the emergency department, it wasn't a question, so it wasn't something that I gave up easily. I did experience the breathlessness and the rapid heart rate, and all those sorts of things were happening at the same time.
The other thing I wanted to draw out for the people who are joining us is the story about your close friend or a relative who found you in hospital to be a bit confused, or
yes. So
can you tell us about that?
One of my really good friends, her mum came to see me when I was in the hospital, and the first thing, like she openly talks about it now, but first thing she noticed was that I was quite disorientated and I was very clammy, and she could sense straight away that I obviously was having I had an infection. So she did mention it to the nursing staff that, could I have an infection, but also sepsis wasn't a word that anyone knew then. So it didn't come up as being that, but there were those slurred speech, the disorientation, all those things happening as well at the time.
And soon after that, you became very sick and were in intensive care, weren't you? So, Robert, you had some questions.
Just a quick question. At that time, when you had recently come into hospital, were you aware, or did anybody tell you if your skin became mottled as well?
So I don't recall that it was, but then I have actually seen a photo that I took myself of my legs, and they were quite swollen. And the photo was in my IV drip had popped out of and I was holding it in the photo, and you can see in the background my foot, and you can actually see my foot, to me, looks like it was turning a little like purplish colour. I hadn't ever thought of that before until I sort of started looking into these symptoms of the mottled skin and things, but it wasn't until I woke up from...
The reason I ask is that we've developed a little mnemonic of sepsis, and you've almost got a full house of the symptoms that we've just talked through, from the slurred speech or slight confusion, the shivering, passing no urine, breathlessness, sense of impending doom, and then the last one here, we've got skin mottling or bluish. in colour, and
But I just don't
really
think
tells the story.
they weren't all put together.
That's right.
Yeah.
And the other thing that strikes me from your story is that it took a number of days for this to really get going. A lot of people who come to hospital with sepsis have been sick for some time. Sometimes it's a day or two, sometimes just hours, but typically 1 or 2 days, up to 5 or 6 days I'm hearing. That's quite a long time to be sick.
Yeah.
It's interesting that the symptoms occurred at different times through the week. Odette, from the people that you've spent time working with in your role as the sepsis nurse coordinator for the hospital, would you say these symptoms are typical?
Yeah, so quite typical of what we see in patients with sepsis.
Yeah. And it's not uncommon in our work to realise that people can piece it together looking backwards but not looking forwards.
Yeah, it is quite difficult on the spot to be thinking whether or not this is sepsis, or whether it's another illness, or whether it's an exacerbation of a chronic illness that somebody might have. Thinking back to that, people with chronic illnesses are more at risk of developing sepsis, so it can be quite difficult to differentiate between the two.
So one of the things, talking about recognition and awareness, that the UK Sepsis Trust have been talking about for almost a decade now is just ask, could it be sepsis? So in where we work, and I know that you've been very involved in the programme that we're working with, if people think about sepsis as a diagnosis, how do we train? Do you want to tell people listening about what our doctors and nurses look for now when they think about somebody who looks ill, who has an infection?
So within our hospitals we have a national early warning score system. So we encourage any health professionals within our hospital system, if they have an early warning score of 3 or more, and are showing signs and symptoms of infection, or if they look incredibly unwell to the health professional and there doesn't seem to be a clear reason for that, to just stop and ask, could this be sepsis?
Yeah. And obviously, further into the clinical tools, which are all available on our website, we encourage people to check for red flags, which are the clinical signs that somebody is very unwell. If they're present in association with the constellation of symptoms which Corin described so clearly, that would be a clear trigger to act and to take further action, which really involves getting help, giving antibiotics, and assessing the infection carefully and providing fluids if necessary and careful supportive care. So, Corin, you found yourself in intensive care.
Yep.
And I imagine that you can't remember very much about that yourself.
I was asleep for 9 days.
Asleep for 9 days. So maybe, Robert, I mean, this is something I've been looking forward to in planning this. Could you just tell us what it's typically like as an intensive care specialist to receive somebody who's very sick with sepsis? What do people and their family and whānau typically go through during a sepsis admission?
So it's a very, very big deal, and we worry a lot about a patient who has developed septic shock, because by the time that it's clearly identified, many of the body's organ systems are in deep trouble already. And we see evidence of this on blood tests. We will also work very hard to go looking for a primary source of sepsis, because you need to find where the sepsis is coming from to get to what we call source control. And it may be that that's not possible directly because it's simply an infection in the bloodstream, or it's something like a meningitis that only really responds to antibiotics and supportive therapy. But it may also be that there's an abscess somewhere, or an active infection, for example, a cellulitis in a leg or some other part of the body, which can be drained surgically. And that's one stream of work. The rest of the stream of work is supportive care, to try and help the body's organ systems to resist the deterioration and to then slowly improve. But it often can be a slow process. Corin talks about 9 days in intensive care with no real memory, and I suspect that was only a portion of your true intensive care stay.
Oh yeah, I was in ICU for 4 weeks.
Yeah, absolutely.
So, and on ECMO for 3 of that.
Which is very interesting indeed.
Time. Yeah.
So for those of you who may not know, ECMO is a modern technology that allows intensive care and vascular doctors to provide an extracorporeal life support system to take over some of the role of the heart and the lungs of a very sick patient. And recently, in the last 5 to 10 years, it's being used a little bit more in the field of severe sepsis and shock, and thankfully with some success, although not exclusively successfully. And it's a therapy that's not available in every hospital. It's a specialist, highly specialized therapy, and it clearly has helped you. The next thing to draw out here is that a patient with severe sepsis and shock, it can be very, very hard to support. And some of the treatments that we give with the intention of helping the patient through the illness can also run the risk of causing damage. And we walk a bit of a knife edge sometimes between providing enough specialized drugs, and we call these vasopressors or inotropic drugs, to keep the body's blood pressure up and to counteract the effects of the inappropriate dilation of blood vessels, which sepsis causes. But we know that the body's blood vessels are dysregulated, and we can give a lot of the drugs that will help the blood pressure to come up, and we may give drugs that help the heart to beat stronger and harder as well. But the consequence of this, in conjunction with the body's immune response to the infectious organisms, causes microemboli, so tiny little blood clots that may appear in the small vessels of particularly the fingers and the toes, and sometimes the larger blood vessels. And if Corin doesn't mind showing us the fact that actually you've ended up with some amputation and a prosthetic arm as an end result. And this is a feared complication of sepsis. Yeah. And I don't know if the people can see, Corin actually has prosthetic legs as well. So my goodness, what a devastating outcome. But I think you also said, thank goodness I'm still here.
Still here, exactly. Yeah. I mean, the other side of the coin is that I could have died, and I should have, because of the survival percentage I was given was only 5%. So somehow I came through, and I'm extremely grateful for.
It does sound like you had an amazing constellation of critical care people around you, but also an element of, perhaps, dare I say it, a bit of luck in that your own body, once it had the assistance of the well, maybe, yeah, but also your body managed to fight things off with the help from the therapies that we, as an intensive care community, can give.
I definitely think it was, I was extremely fit and healthy at the time, and I think that was a huge saving grace in my life expectancy, because I was probably the fittest and healthiest I'd ever been, and the doctors and nurses all said that that's probably what saved my life.
So that's
Tom, maybe you want to speak to that.
Well, I had another question in mind.
Sorry.
We can come back to that. So we've talked about really one of the most advanced treatments that's provided for any patient with sepsis. But what are the more typical interventions for somebody who whānau or a loved one might see of their relative or friend or family member in the bed?
So we mentioned source control, and in hand with that goes high-dose antibiotics, and trying to find the right antibiotic or the right spectrum of antibiotic early on is really important. And then the next aspects are all supportive therapy. So often the body loses fluid into the tissues, and there's not enough blood or fluid circulating with the blood becomes too sticky, so we will give fluids to a patient. And this is one of the great conundrums of intensive care, and the debate rages about how much fluid and when and how and what type of fluid, but we all know that some people will need some fluid. And the trick is just to keep reassessing the patient to see whether they need a little bit more, and there are multiple tools that we have in our toolkit to try and get the right amount at the right time.
Okay, and I can see that Corin has a scar from access to her airway. What does that involve? So
often patients are so sick that they need to be given drugs that put them to sleep, essentially an anaesthetic, and then they have a little breathing tube popped down, usually through the mouth into the windpipe, and that it allows us to alleviate pain and distress. It may actually help with primary respiratory dysfunction, because people's lungs can become very unwell very quickly as well. And as a consequence of that, we need to work out over time, over a few days, whether somebody is likely to wake up quite quickly, within a week or so, or whether they're likely to need a prolonged course in intensive care, in which case we might consider moving on to something called a tracheostomy, which is a small surgical procedure that opens the airway at the front of the neck, and Corin has a little scar just above the collarbones here in the midline, which shows us that she's had a tracheostomy. That is a useful tool because it means we can turn off some of the drugs that keep people asleep, keep going with painkillers if they're required, but also keep a ventilator machine as a supportive treatment in that situation. And it often is really helpful to start someone on physiotherapy and early rehabilitation strategies in that situation to help preserve muscle mass, which we know wastes away very quickly. And then we have to start nutrition as well to help do that.
So what we see on day-to-day work in the intensive care, and Odette has a background as an intensive care nurse, is somebody who's very ill, who's receiving multiple interventions to keep them alive.
Absolutely.
And I guess this might be the time to point out to those of you at home or involved here who have cared for people in intensive care, who've been discharged from intensive care, or if you've actually been in intensive care with sepsis, our figures suggest that the chance of dying in intensive care if you have a sepsis diagnosis is about 1 in 3 in our intensive care, possibly a bit lower depending on the diagnosis you arrive with. Odette, from a nursing point of view, what would that look like on a day-to-day basis? What would Craig have? How would you have worked with Craig, who presumably would have been beside himself at the bedside? How would that work out?
So generally, from a nursing perspective, our role is to almost to talk through what's going on with Corin. So we would have been explaining about the different machines that she would have been attached to, as well as the different therapies, why there was a need for us to be doing certain things at certain times, and then just answering any questions that he might have. But a key thing in those situations as well is that we also encourage the family members to look after themselves in that time, that we are there as health professionals to look after the individual and that they should be taking the time to look after themselves too.
Okay, yeah. Outstanding. So as a way of just quickly summarising what we've been talking about, if you want to know more about the symptoms of sepsis, this leaflet, which Odette and others put together, is available on What is Sepsis at www.sepsis.org.nz. And that is the moment where we're going to ask Corin to tell us about what it was like when she woke up. So what did you remember next, Corin? What happened after that?
Well, I woke up wondering where I was, because I had obviously gone into a surgery at one hospital and suddenly it was days later. I was very heavily drugged and unable to speak because I had the trachea in. Unable to move because, as you mentioned about muscle mass, it had deteriorated. So I lay there wondering where I was and what had happened and all those sorts of things, and had to be constantly told, you're in the hospital, this has happened, you've been in an induced coma, but we're doing the best that we can. And then gradually I went through those processes of taking the trachea out and relearning to cough and talk and all those sorts of things, and physios up on the bed pounding on your chest because my lungs had failed, which was what initially led me to being placed on ECMO. And so obviously they wanted to get all that back, and it was quite a trying time, but I think it was the best place for me to be. So in ICU you have that one-on-one care, unlike when you're on the ward and you have a nurse to 8 patients, or I don't know what the ratios are anymore, but I was extremely grateful that I had that care. And then talking about Craig and the nurses constantly telling him what was happening, that was his survival mode, I call it. So he would put a text message together, he would ring the nurse that had been on overnight and get an update of everything, white blood cells, red blood cells, all my oxygen levels, all these things, that he suddenly became Dr. Homewood. But anyway, but it was his coping mechanism, and he used that to then send out a message to 50 of our closest friends and family, and it was, they learned things that they would never have known the terminology for. And he jokes about the fact he came in one day and I was having a bronchioscopy done, and he's like, oh, now I know it inside and out. So he comes up with all the terrible jokes. But I think it was a huge thing for him to have that support from the nurses and the doctors and everyone, so that he could feel that he was part of the whole process.
So I think the people listening can probably guess at how terrible that is, and stop the clocks, give the dog a juicy bone, whatever that poem is, that really stops life. And I guess that people really realise quickly how much trouble their relatives are in, and spend a lot of time in intensive care. A lot of sepsis is actually managed outside intensive care, and a lot of recovery happens after the intensive care admission. What were the big challenges during that remainder of your inpatient stay when you were out of intensive care? And
I think because when I did wake up and was sort of out of that drug-induced haze, and then saw that my limbs had started to deteriorate, it was being told by the vascular surgeon, we have to amputate your legs to save your life, kind of thing. It wasn't done in quite that manner. It was a little more like, we've got to take your legs off and we can book you in at 10:30 on Thursday. But anyway, so I think dealing with that thought, and then I just had it in my mind, okay, take my legs, that's fine, but losing my hands was probably a lot harder to deal with. So there was 6 weeks between the 2 surgeries as well. So they did my legs first, and then I kind of got used to that whole process, and then they were trying to save as much of my hands as they possibly could, and that the unknown was probably the hardest thing to deal with, because you're already dealing with trying to doing all this physio and all these sorts of things and trying to recuperate. And I was in an infectious disease ward for 4 weeks after 4 weeks of ICU. So you're very sort of closed off from the world, so to speak. But it's a lot to get your head around. And then they did do my upper limbs amputations, and just then trying to get my head around that as well, and where life was going to go from there. So and then I was in a rehab hospital for 5 months.
Gosh.
So
I've seen videos of you during that time, and you looked ill.
Yes. Very, very, very. I'd lost 15 kilos, I think, in the first 2 weeks that I was in ICU. My first time standing up on prosthetic legs, Craig reckons that the forearm support frame that I was holding onto was wider than I was, and things like that. So, it was. A lot of people didn't think I was going to make it.
Well, right.
Because of how ill I was and how ill I looked as well.
Okay. So, Odette, you've been doing a lot of work with people who are recovering. What are the typical challenges that they face, or the questions that they have in that phase when it's clear that they're going to be okay, at least during the hospital admission, but are wondering why they're so, what are they worried about at that stage?
So often we hear of people talking about that they this kind of sensation of brain fog. So this feeling like they can't order their thoughts, so they can't really get out to their friends and their family how they're feeling or what's going on for them. Also issues with things like concentration, energy levels, and they're finding that they don't actually have the words or the language to describe that to the people closest to them. And so the people closest to them are also having trouble trying to understand what's going on with them as well. So often people talk about feeling quite isolated, and they also just talk about the fact that nobody seems to sort of understand, or this term that we use now is post-sepsis syndrome, which basically is just a term that we use to describe all of those kinds of symptoms that people are experiencing post-sepsis.
Yeah, and I think that's a beautiful compliment to Corin's explanation of how much weight and muscle she had lost. So when we've talked about post-sepsis syndrome to GPs and to people who we think are suffering from it, we talk about a brain muscle syndrome. It's not everything that goes along with recovery. It's that brain fog, loss of concentration, depression often goes with it. And we know that people who've come out of intensive care often have post-traumatic stress disorder. It's very common, need a lot of psychological support. And then if you imagine that your muscles are half as strong as they used to be, what kind of problems do you have? Standing from chairs, climbing stairs, fatigability, doing the dishes, catching up with the kids.
And I think everyone, all sepsis survivors are we're all at different stages too of survival, so to speak. So a lot of people can come out of hospital and not have any physical attributes to that sepsis. Like mine's very visual. So on top of having the amputations, to also have the cognitive, the fatigue, and having bilateral below knee amputations means that it's 80% more energy just to walk than an average person. So I've got that on top of already having the sepsis symptoms as well. So I think a lot of people out there find it very difficult to get it across to their friends and family, like this is actually a disease, and it's not visual, but it can really affect people's mindset and things.
That can be very upsetting, I guess.
Yeah.
And I think if people have come into hospital with something like a heart attack or a myocardial infarction, it's got a sort of list of things that people expect to happen to them, and hopefully they will improve and get better from. But then when they go home again, there's also a list of things that will happen. They will be plugged into some kind of cardiac rehabilitation program. They will see their GP regularly for checks of their blood pressure. But when you move to sepsis, there's no one specific group of doctors or organisation that follows people through and provides support thereafter, partly because it may affect so many different body systems, and partly because the system isn't really set up to look after people that way. And you've pointed out that you've had some very visual to other people and very, very physical to you effects of the consequence of sepsis. Some people may come out of hospital with none of that, and they may look to other people as if they're normal, but they clearly don't feel normal inside.
And it's trying to explain that to people, that, you know, there's a lot more going on than what you can physically see. So,
and I think the studies would really support that. There's quite a lot of data coming out of long-term sepsis follow-up that people take at least a year to get back to not even baseline, but something a bit like that. And then over the next few years, they will re-establish physical activities, mental activities, return to job, study, work, and all those kind of things. And critical illness of any kind, but particularly of sepsis, is incredibly debilitating and carries forward with someone through their life. And unfortunately puts you at risk of having something else like that in the future. And it's not uncommon for us to see somebody who had severe sepsis in ICU and at some point later in their hospital stay gets another episode of sepsis, which is dreadfully upsetting and unfortunately is very hard to prevent, other than simple measures like staff washing their hands and maintaining hygiene standards. But some people are just susceptible.
But also looking after yourself as well. It's, you know, and recognising the signs, I think, is the big things. Like, now that when you've had it, and then now to know the symptoms of it, it's recognising that and thinking, okay, I really need to go to the GP or to the hospital and get through this, because
So just to talk to the audience, if you would like to play around with Zoom, send in some questions. Aware that we've managed to answer some of the questions that have been coming in. Thanks particularly to Max, who's sharing his sepsis journey with us as we go along. We'll try and draw out some of these questions into the conversation as we move along. Please do submit them. So that's your, you know, the key features of your recovery, and it's fantastic to see you doing what you're doing now. Looking back, what kind of support would have been beneficial to you during that time, the early recovery phase, maybe in the first year, when you were going through the brain fog, muscle weakness, uncertainty part of it?
I think what often happens is, so in my case, because of having the amputations, there was a huge focus on that for my rehab and everything. I did voluntarily undergo a lot of cognitive testing and part of research for the hospital, but they sort of came to me and asked if I was interested in doing that long term, and that carried on after for the first year of me being out of hospital. But I think the problem is that you can go to your GP and say that you're experiencing these symptoms, and they can brush them off a little bit of, oh, no, you're not experiencing that, or there's no such thing as post-sepsis syndrome, which I've heard numerous times from people.
Yeah, in fact, we have a comment from one of our contributors. We need to get more help for post-sepsis syndrome. I had no help at all and still have to suffer medically 10 years after the event.
Yeah.
Would you agree that that's an
I do think that is because it's not recognised and it's not put out there. And to flip the coin though is we're all so different, and everyone's got such different outcomes from their sepsis journey. So it would be very difficult for a GP or the medical industry to go, this is how you cope with someone who's had sepsis, because that might work for that one person but not for these other 10. So I can understand that it would be very difficult, but I just think there needs to be more recognition of the symptoms and the ongoing issues with it as well.
We had a mutual acquaintance who was prescribed Xbox
Yes.
for his brain fog, and I was always very grateful for that. So yeah, horses
Yes,
for courses.
he still talks about it now.
Yeah.
And all his friends want to be prescribed Xbox for anything that they have going wrong. So
Yeah, fantastic.
There's a question here from a participant, just maybe who missed the very beginning of the webinar, asking what causes sepsis. So is it a good time to just do a little bit of recap to remind people about that?
Sure. Well, I think what we've been talking about is how sepsis is a dysregulated immune response to infection. It causes a lot of tissue injury. It's hard to diagnose because that injury accumulates over time. So the very earliest symptoms can be quite non-specific, and they accumulate, as Corin was able to demonstrate to us, in different combinations over time, depending on what organ is being damaged and what the actual underlying infection is, and whether people have received any treatment. That's why it's hard to diagnose. Another question I've seen coming through the chat is there a blood test?
Yeah, absolutely.
Would you want to tackle that one?
So, well, that's a good question, and I think the problem is that no, at the moment, there's no single blood test or any other test that categorically tells us that this patient has sepsis. There are a constellation of tests that we, as doctors and nurses, healthcare professionals, can look at together that put together the jigsaw and strongly indicate that sepsis is likely in this patient. And those would be a mixture of tests that tell us about what the body's response to inflammation, so whether the body is getting the blood to the bits that it needs to, and stuff called lactate that you may have heard of that builds up in your muscles if you're running a marathon. It also builds up in your bloodstream if you have sepsis and inadequate blood supply to the organs. But it's non-specific. So you need to tie that together with a good story for an infectious illness and the other symptoms that we've talked about already, the slurred speech or confusion, the extreme shivering, the absence of urine, sometimes breathlessness, even a patient's subjective experience that they feel like they're going to die, this is the worst thing they've ever experienced, is a strong indicator that this could be sepsis and septic shock. Yeah. And then a late sign, but a very worrying one, would be mottling of the skin or cold peripheries with the blue of the fingertips. That'd be very worrying indeed.
Okay. So moving through to opportunities to improve, there's a few we could cover off. And Odette, you've been very busy implementing what we've called locally the Sepsis Ready program at Waikato Hospital. What does that involve, and how has it worked? What have been the benefits?
So essentially we have developed and introduced clinical tools within the DHB's 5 hospitals, and the tools aim to help clinical staff to recognise sepsis early and to respond to it quickly. And we supported the implementation of those tools with education, so face-to-face education, and also with an e-learning package. And also just through other awareness activities, so posters. For the month of September, we've been doing sepsis tea trolley teaching, so going through all the clinical areas just to continue to raise the awareness of sepsis amongst our health professionals here in the hospitals, because that's part of it, is that people have to consciously be thinking, could this be sepsis, when they are faced with an unwell patient in front of them.
And we've found again and again, it's the frontline staff, isn't it? It's the ward registered nurses overnight, it's the emergency department nurses, it's the doctors in often the first 3 to 5 years of training, who are faced with assessing people as they come through in public hospitals, who are actually having to make these decisions. So it's quite an unusual program in a way, isn't it? Because other programs for other critical medical emergencies like heart attack and stroke rely on getting you to a specialist as soon as possible. But because sepsis is caused by any of a number of infections, it can go to any of a number of departments at any time of day. Any individual staff member will often see very little sepsis, but they're responsible for recognising it and responding to it. So thanks for allowing me to comment back to you on the program that we've been implementing. For those of you that are watching, Odette's wearing the red lanyard and the sepsis symptom card on her neck and is using a sepsis pen, as is Robert. So these are the kind of day-to-day awareness tools that we're distributing around the hospital, and that goes with the byline to just ask, could it be sepsis? Which is what we're really just trying to encourage everyone to think as they deal with the sickest of their patients who have infection.
I was just going to comment that the just ask could be sepsis byline and phrase is really, really useful in the public arena and in the outside of the hospital zone, because this is a problem of awareness amongst our communities and whānau, as well as within medical professionals in the healthcare system. And I think you've already mentioned some GPs maybe not have enough awareness about this, and I think this would be echoed by the information that we have too. And asking people who are concerned about a loved one or themselves to ask the GP or the rural nurse or whoever it is they see, could this be sepsis? Sometimes is enough just to trigger a series of events that either bring them into hospital for more assessment or ask them to come back in 6, 12, 24 hours if things are no better. And that's a story we really want to get out there, isn't it? And it perhaps reflects in the fact that we took a stand, not dissimilar to this, to field days this year and got out there to speak to the public in as much as we could.
So what other opportunities do you think there are to improve and prevent sepsis around the country, Robert?
Well, it's a great opportunity to look at the big picture, and I'm pleased to say that the Sepsis Trust for New Zealand is working in close collaboration with ACC and Ministry of Health and Health Quality Safety Organisation and many other interested stakeholders to try to develop a national sepsis action plan, which really encompasses many of the things that we're talking about already. It's about awareness of the public and professionals, and it's about doing the right thing for the right patient at the right time, meaning early identification of the patients who are becoming sick with sepsis. And then as time goes by, we want to move into that space of supporting the survivors. And this is really, really crucial. And it's definitely coming through in some of the comments that we've got coming into the webinar about sepsis survivorship is a very, very big deal. And there isn't really a satisfactory system at the moment to support people in that space. So we would very much like, as a trust, to find a role for a sepsis support nurse, to be some point of contact for survivors out there, who can then put them in touch with other services if required, provide advice, and just take things forward. And perhaps this will become a role model for the DHB system that starts to see it as a necessity rather than as a luxury. And we can see how that evolves over time.
Yeah, and that's certainly a major focus of fundraising for the Trust in the next 18 months, is to generate enough funds to cover the costs of employing somebody who can speak with people who are recovering from sepsis, often after that critical post-hospitalisation phase, when you're back in the community and facing doubts and concerns and navigating the healthcare system. I would think it would be wonderful to have that person available to the very many people who do present with sepsis. And that's a segue to remind me to point out that not all segments of society suffer sepsis at the same rate. So our work at the Waikato District Health Board has pointed to poverty, and related to that, but somewhat separate, is the increased risk of Māori for sepsis. The risk indicated to be about 3 times greater than non-Māori in the Waikato District Health Board. Robert, what's driving that, do you think? That's a big challenge for New Zealand, but what's driving it?
It's a very big challenge for New Zealand, and it is actually reflected in data from other countries around the world, that people from Indigenous groups and the disadvantaged groups suffer disproportionately more sepsis. And there's many issues around this that are associated with access to healthcare and information about health, and people often will tough it out and suffer their symptoms. And as you mentioned already, that sepsis often evolves over 2 or 3 or 4 or 5 days, and people that tough it out thinking they've got the flu or a bad cold or just a bit of a scratch on the leg or whatever it is, and then maybe present when the sepsis is already quite established. So there's an education issue there, and that applies to everybody. We certainly need to help that space and encourage people to do simple things to look after their health. So, good diet, avoiding smoking, getting vaccinated, all the sort of healthcare messages that we're very, very keen to share, but come out of many areas, not just out of sepsis.
And part of the work that we've been doing as a trust is recognising that we need to provide high quality information in a way that people want to receive it. So in Te Reo Māori, for example, there will be a translation of this leaflet available to people in Te Reo Māori on our website within the next 1 or 2 weeks. That's work that the Trust has commissioned to help everyone in New Zealand.
Did you notice that I wasn't asking for fancy equipment for intensive care like ECMO and things? I mean, that's very useful and nice, but it only supports the few. And as we've already said, if we can catch people early in their journey towards sepsis, we can actually
get to that stage.
divert them. They don't get to that stage, Corin, as you say, and they can recover on the wards in the hospital. And occasionally, that can really help a lot, and we can avoid the need for intensive care, which is clearly better than the
Excellent. So a comment from a nurse who appears to be working in rural practice. It's high time that people other than doctors are permitted to prescribe antibiotics where medical help is not readily available. How do you feel about that, Adette, as the nurse member of the panel?
You're putting me on the spot here, aren't you?
Yeah.
I definitely think that in certain situations there is a place for it, but there is things obviously that come along with it, with the ongoing education and upskilling and things around it. So having that knowledge around antimicrobial prescribing, etc., to go along with that. But yes, I agree that there is definitely a place for it, especially when you are in those areas where waiting for a doctor to prescribe antibiotics will cause delays, knowing that antibiotics are quite key in the treatment of sepsis.
Is that a good point, just to mention the issue about careful use of antibiotics?
I think so. What we have heard again and again is we are hearing that we need to restrict the use of antibiotics. And we need to be quite careful about this message. As an infectious disease specialist responsible for the quality prescribing of antimicrobials in this hospital, or partly responsible for it with my colleagues, that message is correct. We do need to be restricting the use of these precious drugs. And that means not prescribing them if somebody's clearly got a viral infection. But I think what's important to point out is that doctors are very fearful of infection because they've seen people with sepsis. And that comes through in the research again and again. People understand the need to restrict the use of antibiotics, but they have seen bad outcomes due to infection, and they don't want that for the person in front of them. And so we have to find a way to help people to make good decisions about antibiotics. For example, the tools that we've introduced into the acute medical receiving unit where I work have allowed me to judge who definitely needs antibiotics, who might need antibiotics, and who probably doesn't need antibiotics. And a lot of times now I'll decide not to give antibiotics to somebody who is not exhibiting signs of sepsis when we're not sure if they have an infection. That's just one example. But in all of these messages, it's important to remind people that we're trying to preserve antibiotics so that they work when people have sepsis. And actually finding balance in that messaging is actually critical to making sure we don't restrict the use of appropriate prescribing where it's
at the right time
necessary.
Yeah.
Which Corin's nodding away. None of us would want to be declined antimicrobial therapy if we were ill.
That's right. Yeah. And that comes back to this difficulty in getting a clear diagnosis early when we know that the right treatments can change someone's course to a less severe end of the sepsis spectrum. So it is difficult, and it comes back to all of those tools that Adette was talking about earlier, using early warning scoring systems, a constellation of blood tests, and sometimes just good old-fashioned clinical instinct, where this patient is really sick, or actually I think they're getting a bit better, they've responded to the simple treatments we've given, this probably isn't sepsis, it's something else.
And a part of recognising sepsis early, often people who've had excellent treatment early on do better and need less antibiotic exposure. And just to address a comment about having lots of courses of antibiotics, you don't want to select out the very resistant infections that people can get after they've been admitted to hospital. So lots of good points coming up across from the chat and from all of the panellists. I think what I might do there, because obviously we've scheduled this to run from 2 till 3, and we've had some excellent commentary, we might just leave it there and thank all the panellists, and particularly Corin, for sharing that story with us. So I might draw the webinar to a close there. If anybody has any follow-up questions, you can address them to info@sepsis.org.nz. We'll be following that email quite carefully for the next week, just to make sure anybody who's been participating in this gets prompt responses to any lingering questions. And the link to this webinar will be released on our Twitter channel and on our website in about a week. So thanks to all our friends at Mobile Health, Waikato District Health Board, and the New Zealand Sepsis Trust who've made this possible. Thanks very much.
Thank you.